questions. Because we want to see what's going on here. Because if they've gone yesterday, they haven't gone today, probably haven't eaten for 24 hours, of course they're not going to have anything to go. Regardless if you've eaten or not, you're going to have some kind of bowel movement. Okay? Your body still produces a mucus to help move through the stool through it. So you will have some kind of bowel movement. It's not the bowel movement that they're used to. People are used to stool. So you have to ask the patient, have you had any kind of movement or mucus coming out? Okay? So that's normal because if the bowels will try to move something. All right? Okay. Anything else about GI? GU. Patient has a Foley catheter. I'm going to go here and inspect the Foley catheter. So I'm going to put on my gloves. Okay? I'm going to come in here. I'm going to inspect the Foley catheter. I'm going to grab the catheter and slightly tug on the catheter. I don't have a catheter here so you guys can't see it. So I'm going to slightly tug on the catheter. Okay? Just check for placement. And as I loosely do that, then I'm going to actually go back and insert it again. The reason is I do not want, when I go and pull that off of I'm pulling it against the bladder wall. So I need to go back and release that pressure from the bladder wall. So I'm just checking for placement, but I want to release it from the bladder wall. Okay, so there's no tension there because that's going to become the product if it sits there. Okay, so I check that. I'm checking the tube, making sure the tube is okay. Is it strapped to the leg? Is it there? Is it over the leg? Is the loop should be on the bed, not dangling. Okay? The loop should not be dangling like this. Why?
Because it'll catch. It won't push through.
It can drain. What's another reason? Microbiology. Okay, because it starts staying static and it's going to start growing. Urine grows bacteria very fast. So you don't want that loop being dependent. It needs to be up on the bed so that the gravity is pulling it into the bag. Okay, so make sure that Foley catheter is, that tube is up here, and then the Foley catheter is coming to the bag. Come down to the Foley catheter and inspect the Foley catheter. So I'm going to look for color, clarity, odor. Okay, so I'm looking, is it clear? Is it cloudy? What color is it? Yellow. I want to see how much fluid is actually inside here. So I need to measure the amount so I know. And so that I can make sure that we're getting enough urine output. Should talk about how much urine output we should have each hour?
30.
About 30, okay? So we should have about 30. So.
She knows that.
No, she's told us that.
Okay. Okay, so make
You
sure.
know that already.
Oh yeah, and that was in the lecture.
So, okay, so make sure. If we don't have that amount, then we need to be aware of that. So a patient who is on a Foley catheter is automatically an INO. Okay, they're automatically an INO. All right. But nowadays you're seeing less and less Foley catheters. So, some of you might get experience putting one in. Some of you get more experience putting Foley catheters in during your OB rotation because they're reducing the amount of Foley catheters used in the hospitals as much as possible because of the UTIs. All right. So we double check that, make sure that's there. Foley catheter is there. Now, patient doesn't have a Foley catheter. I'm not going to go and inspect the patient. Going to ask the patient the same things I just looked for. Okay? When's the last time you used the restroom? Did you get up? Do you have to go now? Do you want me to escort you there? Do you use a bedpan? Did you use a urinal? Does it burn? Does it hurt? Does it, all that stuff during urination. Okay? All right. Once I do that, then I'm going to go down to my lower extremities and I'm going to inspect one side of the leg. So I'm going to come down here, inspect the leg, coming down, feeling down the patient's leg. Okay? I'm feeling for what? Okay, any kind of, again, lumps, bumps, or bruises. I'm also feeling the skin temperature. I'm also feeling for any kind of heat. Okay? This is normally where we get our DVT.
Deep vein
vein
thrombosis.
Deep vein thrombosis, okay. So, we used to do a thing called Homan sign. We don't do that any longer, okay? So,
What is?
I'm not gonna show you because I don't want you guys to do it. So we don't do that anymore, so we have to still check for it some way or shape or form. The reason we don't do it anymore, because the way we would do it, we could dislodge a clot if we did it, okay? So we don't do it anymore. But we still need to assess the patient's leg. So we're going down the extremity, feeling their leg, feeling for any, again, lumps, bumps, or bruises, but I'm feeling for skin temperature all the way down the extremity, okay? Asking the patient, do you feel any pain or discomfort? Patient says, yes, I feel pain. Describe that pain to me, okay? You really want them to describe the pain, because any patient who's been lying in bed for long periods of time, what happens when you lie in bed? No, it's like that. What happens when you're just lying in bed for a long period of time? Circulation starts to go down, and so your feels kind of feel like they ache, right? So we need to ask the patient, what is that? Is that pain, or is it an achy pain, or is it achy? Because we want to know. If it's pain, then I'm worried about that. If it's achiness, okay, you know what? You need to do some exercise. Move your feet. Okay. So we'll do some ankle pumps and stuff like that to get them moving. Go ahead and feel their leg all the way down. I'm going to feel for my pedal pulse, my pulse here. Okay. I'm going to come down here. Feel, what is this pulse down here?
Pedal.
What's this one?
Tibialis. Posterior
So I'm going to
tibialis.
feel for my, good luck trying to find this one. You're never going to find it. Okay, so go ahead and feel it. Feel for my pulse, okay. Check my cap refill. Okay, how the patient push down on my hand. How the patient push up on my hand. See if they can actually bend their leg. And see how I'm holding their leg? Have them do that. See if they can bend their leg. They don't have to go all the way up. Just bend their leg, see what they're doing. Okay, and then I'm going to check for the heel to make sure if there's no decube. Okay, come over here. Come to this side. I'm going to do this side of the leg now. Same thing. Okay, and then what I'm going to do is come over here and look at them both, bilateral. So now I'm looking for symmetry, making sure that they're both okay, they're both symmetrical, there's no edema, okay, and both heels are okay. Don't do this to the bed. Your CNA just came and made the bed and you guys are tearing it up. It drives me crazy. I teach CNAs too, so it drives me crazy. Get them all making the beds nice and neat, and the nurses go in there and pull the bed apart. Okay, so then I come over here, I'm going to do the same thing on this arm, check all the extremity strength and stuff like that. At this point, I'm going to either have the patient sit at the edge of the bed, if they're able to get up, or if not, then I'm going to have them go ahead and turn to the side so I can look at their back. I'm going to listen to the lung sounds in the back. How many?
10.
10 sounds on the back, all the way down, okay? Then I'm also going to be looking for all the bony prominences. So we're looking for any kind of skin breakdown, okay? All the way down, you're going to look at the buttocks and make sure that they're clean and that there's no breakdown and there's no rash, because sometimes people who are in the hospital and whoever's doing the baths or they have a bowel movement in a bedpan, then often clean them good enough. So you want to look for any kind of breakdown, okay? Have the patient come back, set them back in their bed, ask them if they need anything else, call light, and we're done.